Assalamualaikum warahmatullahi wabarakatuh. In this video, me, Nur Ashiki binti Wahidin, and Siti Haja Natasha binti Samsudin will present about the recent development of insulin production to treat diabetes. We first start with the introduction of insulin. What is insulin? Insulin is a hormone that regulates the amount of glucose of sugar in the body and is required for the body to function normally. People who do not produce the necessary amount of insulin have diabetes. The most severe type is known as type 1 diabetes or juvenile onset diabetes, while type 2 diabetes is the most common form of diabetes. The major risk of type 2 diabetes is obesity. There are 5 types of diabetes, which are rapid acting, short acting, intermediate acting, long acting, and mixed insulin. Nowadays, insulins are produced by recombinant DNA technology that use E. coli and yeast, such as Saccharomyces cerevisiae, for the production of insulin. Next, we go through the history of insulin production year by year. In 1869, Paul Langerhans identified that islet of Langerhans produced a secretion involved in digestion. Next, in 1889, Oskar Minkowski and Joseph von Mering found that if they remove the pancreas from dogs, the animal would develop diabetes. Several years later, in 1907, a Belgian investigator, J. de Meyer, proposed it be named insulin. Next, in 1916, Shapley Schaeffer in Britain independently suggested the same name. 4 years later, Frederick Banting came up with a successful method after reading an article by Minkowski. Marcliot agreed to give Banting spare dogs and a student assistant for an experiment. A year later, Banting began his research assisted by Bess, one of the Marcliot students. At the end of July, they observed a pattern of hypoglycemic effects. December, Banting and Bess had accumulated further evidence of their extract reduced blood glucose of diabetic dogs. Because of Bess' inexperience, Marcliot and Banting decided to add J.B. Collip to the research team. By the next year, clinical trials began. Doses of purified insulin were successfully injected into diabetic children. The pharmaceutical company Eli Lilly started to produce purified insulin. A year later, which is in 1923, Banting and Marcliot's effort was paid off. They were awarded for the Nobel Prize for Medicine, which they chose to share with Bess and Collip. Insulin continued to develop by the year of 1930 when H.C. Hagedorn prolonged the action of insulin by adding the protamine. Next, in 1978, the first recombinant DNA human insulin was prepared by David Goedel. In 1982, the first insulin utilizing rDNA technology, Humulin R and N, were marketed. In 1993, diabetes control and complication trials show for the first time, without any doubt, the linear relation. 3 years later, in 1996, Lispro was the first short-acting insulin analog approved. In the year of 2000, insulin analog Aspart and basal analog Galgin was produced. In next 4 years, insulin analog glycine is produced. Lastly, in 2006, the first inhaled insulin was developed by Sanofi, Aventis, and Pfizer. As was mentioned in introduction, there are 5 types of insulin, which are first, short-acting, second, rapid-acting, third, intermediate-acting, fourth, long-acting, and fifth, mixed insulins. I will give a short review about the 5 types of insulin, which is the first one, short-acting insulin. Short-acting insulin, typically, they are clear solution at neutral pH and have a minor amount zinc for greater stability and shelf life. Rapid-acting insulin include when injected subcutaneously, these analogs rapidly dissociate into monomers and are rapidly absorbed due to their low density for self-aggregation. Next, intermediate-acting insulin. This type of insulin is often combined when needed with rapid-acting or short insulin. Next, the long-acting insulin. Long-acting insulin covers insulin needs for about 1 full day. This type of insulin is often combined when needed with rapid-acting or short-acting insulin. Last but not least is the mixture of insulin, which consists of isofen or regular insulin and NPL or lispro insulin. This table shows the onset of insulin, peak effect, and the duration of action for each type of insulin. For the short-acting insulin, consists of regular insulin, which have the onset of 30 to 60 minutes, the peak effect of 60 to 180 minutes, and the duration of action, which are 6 to 10 hours. Next, for the rapid-acting insulin, which are included of insulin lispro, insulin aspart, and insulin glycine. Insulin lispro have the onset of insulin in 15 to 30 minutes. The peak effect for the insulin lispro is 30 to 60 minutes, while the duration of action is 3 to 5 hours. For insulin aspart, the onset of insulin take about 10.2 minutes to 19.8 minutes, while the peak effect is 30 to 60 minutes, and the duration of action takes about 4 to 5.3 hours. And lastly, for the rapid acting is the insulin glycine, which take about 15 to 25 minutes for the onset of insulin. The peak effect takes about 30 to 60 minutes, and the duration of action takes about 2 to 3 hours. Next, we go through the intermediate acting, which was consists of NPH that take the onset of insulin about 60 to 120 minutes. The peak effect is 360 to 840 minutes, and the duration of action is 60 to 24 hours. For the long-acting insulin, insulin intermittent take the onset of 180 to 24 minutes, the peak effect for 360 to 480 minutes, and the duration of action for 6 to 24 hours. That's all for me. Thank you.
My name is Siti Hajar Natasha binti Samsudin, matric number 2020602002.
Type 1 diabetes occurs because of the immune system mistakenly assume that parts of the pancreas, which are beta cells, must be destroyed. The main role of beta cells is to sensitively increase blood glucose levels and respond to insulin release. Beta cells are basically the only insulin to generate cells in the body. Thus, when the immune system attacks the beta cells, the body's main insulin factory is destroyed, leads to unchecked blood glucose. Type 1 diabetes also occurs because of genetic and environmental triggers. Symptoms of type 1 diabetes usually appear for 3 to 4 weeks before diagnosis and generally are linked to glucose osmotic effects. Popular symptoms include polyuria, polydipsia, severe tiredness, substantial weight loss, catabolic growth, blurred vision, and frequent regenerative symptoms. For children and teenagers, the prevalence of type 1 diabetes is higher and can occur at any age. The presence of autoimmune beta cell destructive serum markers such as islamic cell antigen ICA autoantibodies, glutamic acid decarboxylase 65 GAD65, and insulinoma associated antigen 2 IA2 support diagnosis of type 1 diabetes.
Rosanna and Christina stated that diabetes type 2 is usually caused by a combination of genetic and environmental factors. The genetic factor is stronger than diabetes type 1. However, Elizabeth and Natasha Jacob stated that type 2 diabetes occurs when a person can still produce insulin normally, but the individual's tissue is sensitive to the hormone, such as insulin resistance. Diabetes of type 2 can also occur if the development of insulin itself is impaired. However, for most people, this is usually as a result of long-term overproduction of insulin in response to insulin resistance. Obesity is the main risk factor for type 2 diabetes. Type 2 diabetes symptoms are generally insidious due to a time decline in insulin production. Polyuria and fatigue are typical symptoms. Polyuria increases and nocturia due to the high hyperglycemia. Fatigue because of glucose cannot be used as a source of energy. Sometimes these signs are associated with a rapid, unhealthy weight loss due to the breakdown of protein and fat as an alternative energy source. Vision blur caused by a refractive changes in the lens, but the patients involved should rest assured they can improve their vision with regular glucose levels. Some patients also suffer from infections, especially candida and urinary tract infections, because the rise serum glucose impairs the function of phagocytes that provides a growth medium in which microorganisms can flourish. Yeast is the preferred place to express many heterologous proteins that involve biological changes after translation. Yeast cells can perform many post-translation modifiers, including phosphorylation, all-link glycosylation, aniline glycosylation, acetylation, and acylation. Recombinant proteins are yeasted and correctly folded to functionally active forms in a soluble way. One major concern is that the yeast and glycosylation is the form of high-manus, giving a fast and hyper-immunogenic half-life, thus making the therapeutic glycoprotein less successful. Like E. coli, recombinant biopharmaceuticals have been developed from yeast, mainly intended to be treatment for infectious disease or endocrine and metabolic disease. In addition to Saccharomyces cerevisiae, alternative yeast strains are explored for large-scale biopharmaceuticals development, specifically through its robust and methanol-inducible alcohol oxidase 1-AOX1. Pichia pastoris is able to achieve high cell densities and simple developmental approach that lead to high quality and volume production of recombinant proteins. Pichia pastoris offer a significant benefit in glycosylation of secreted proteins as it does not hyperglycosylate heterologous protein in contrast to Saccharomyces cerevisiae. The length of the oligosaccharides chain added to proteins in Pichia around 8 to 14 minus residue per change is much shorter than those expressed in Saccharomyces cerevisiae, approximately 50 to 150 minus residues per side chain. This indicates that Pichia pastoris developed proteins may be best suited for human therapeutic use.
E. coli expression for production of insulin. E. coli is a favorite microorganism for large-scale recombinant protein development. Nevertheless, many inconveniences limit the use of recombinants for biopharmaceuticals development. Different post-translation modification (PTMS), such as glycosylation, phosphorylation, proteolytic processing, and disulfide bond formation, that are important in biology are not present in E. coli. The most popular post-translational modification of proteins in eukaryotes is aniline glycosylation. Although the bacterial and glycan structure differs from the eukaryotic structure, engineering of Campylobacter aniline glycosylation in E. coli offers a way to express glycosylated heterologous proteins in E. coli. Conclusion: we can conclude that the production of insulin has an impact in medicine, especially among diabetics. Before researchers discovered how to produce insulin, people who suffer from type 1 diabetes had no chance for a healthy life. Then, in 1921, Canadian scientists Frederick G. Banting and Charles H. Best successfully purified insulin from dog's pancreas. In 1982, the Eli Lilly Corporation produced human insulin by genetic engineering. Without needing to depend on animals, researchers could produce genetically engineered insulin in unlimited quantities. It also did not contain any of the animal contaminants. These are references that we use for this article review and A1 poster. So that's all from us. Thank you for listening.